everyone. Thank you for the kind introduction. And to simplify this whole title between what are the similarities and differences, I can boil it down to if you have one of these, you don't have the other. And we can stop there and take questions a little bit later. But let me try to bring it all together and make you understand why it's going to be important for you to understand how we approach these disorders, because things are going to be coming down along for MS that are going to be, I think, very favorable in the way they've developed for neuromyelitis optica. And so when we're seeing a neurologist and there's a problem with inflammation in the central nervous system, we're thinking about several different diagnoses. And we've tried to sort these diagnoses out historically by what is their presenting symptom? What parts of the nervous system are affected? How severe are the symptoms? How good has the recovery been from an attack? Those sorts of features have tried to help us differentiate these many different disorders. But recently, we thought more about the biology of it. What is the target of this inflammation in the central nervous system? And today we're going to focus on two of these disorders, multiple sclerosis and neuromyelitis optica. And I'm going to show you why focusing on the biology is going to be particularly effective moving forward. So about 150 years ago, when we knew about both of these disorders, we thought neuromyelitis optica, or NMO, was a severe form of multiple sclerosis restricted to the spinal cord and optic nerves. Then about 20 years ago, with the discovery of a target for neuromyelitis optica, we thought, well, it's sort of different, but there are a lot of overlapping things about it. But once we understood the target and the biology, we now know that they're totally different disorders with different biology, different therapeutics, and different approaches to management. So we're going to go over diagnosis, pathogenesis, and treatment, looking at both of these disorders. And we're going to start with neuromyelitis optica, which is neuromyelitic optique aiguë, as described by Eugene Devic in about 1894. And he described it as bilateral optic neuritis, either both eyes or one eye alternatively, usually resulting in complete yet mostly transient severe vision loss, and fully, but not necessarily fully, recovery with diffuse or localized myelitis, or inflammation of the spinal cord. As in most cases of medicine, he really wasn't the first to describe it. And I've listed on the right several up to 50 years ago, colleagues of his that described cases that were likely neuromyelitis optica. And those included people who had both brain disease, eye disease, and a presentation that we currently understand, which is protracted nausea, vomiting, and hiccups, which comes with neuromyelitis optica. So in 1999, when the current era was starting to approach this disease, again, we took it from Devic's description. You had to have optic neuritis and you had to have spinal cord inflammation. So essentially, you had to have vision loss from optic nerve inflammation, and many of you have had it from multiple sclerosis, and you had to have weakness, numbness, bowel or bladder problems from spinal cord inflammation, and many of you have had that from multiple sclerosis. And so there wasn't anything specific to differentiate it, but we invented some other major and minor criteria to try to make it clearly distinguishable between the two disorders. It was still a rough going, and it wasn't until 2004 when a target for antibodies in neuromyelitis optica was identified. And this was an antibody against the aquaporin 4 water channel. And the original test was about 70% sensitive, 30% could still have it and be missed, but it was very specific. And most importantly, patients who had this antibody had diagnostic criteria for neuromyelitis optica, but did not have multiple sclerosis. So it was very specific. But what was more important about identifying something that could be diagnostically specific was the fact that this antibody wasn't just a marker of disease, it was driving disease. And what I can say is from our laboratory and others, where I was able to identify the exact antibodies in patients, and remake them in the laboratory, we were able to show that if we injected these antibodies into animals, and lots of pretty pictures of animal pathology there, whether we injected them directly into the brain or whether we put them on slices of animal brain, we could reproduce the pathology of neuromyelitis optica. An antibody in the presence of complement to drive damage could cause loss of astrocytes, the cells expressing aquaporin 4 in the nervous system, cause inflammatory cells to come into the nervous system. And I don't know whether I have a pointer at all, so you'll have to take my word. Oh, I got one here. So we got inflammatory cells coming into the nervous system, complement deposition, and you can tell from here when the astrocytes are there in green, they're all destroyed once you have antibody and complement present. So what we developed was more and more sensitive tests for this antibody. So now it isn't just 70% sensitive, it's about 90% sensitive. So if you meet clinical criteria for neuromyelitis optica, you generally have this antibody. And in the next few years, we're going to make it that you have to have the antibody because we figured out the people that don't probably do not have the exact same disease. And so the target is astrocytes. And if we depend on the antibody, we realize that not everyone presents with optic nerve inflammation or spinal cord inflammation. Some patients can present with protracted hiccups, nausea, vomiting. They can have confusion. They can have narcolepsy, profound tendency to sleep. They can have appetite problems. And so once we know a target, we can start to broaden the presentation and identify people at an earlier and earlier time. So this disease is not just inflammation of the nervous system. It's an astrocyte-targeted inflammation that can look like some other diseases, particularly when it presents at a clinical level. So what about MS? MS, as you're all aware of, we have to have attacks in time and space that affect the nervous system. And these tests can be having a certain pattern of lesions as we look at them on an MRI scan in your brain. And we can look for time-based patterns that even aren't there at clinical symptoms when we sample your spinal fluid. We can look for spinal fluid oligoclonal bands, and we look for attacks and evidence of change over time. And that's our definition of multiple sclerosis. You notice how it doesn't have a target involved for all this inflammation. And of course, we need no better explanation. So we're looking for these signs and symptoms, and then we say, well, it fits the pattern, and I don't have a better explanation, so I think it's multiple sclerosis. So you imagine there's a lot of holes in that. What are these oligoclonal bands? They're actually antibodies, like the antibody I mentioned that was targeted against aquaporin 4 and neuromyelitis optica. And these antibodies that are present in the spinal fluid, as you can see in the arrowed columns here, but not present in the blood over here. So this group of antibodies here are not a specific sign for multiple sclerosis. They're actually just antibodies that are made specifically within the nervous system. 93% of MS patients have them, and they're present at all stages of the disease, whether the disease is active with symptoms or not. And with higher levels of those antibodies, it's been prognostically worse disease. So, and why are they not specific? Because we see them in other disorders of the nervous system. And I've listed a couple of them here, and I'll just have you notice that all these fancy words over here relate to diseases that are infections of the nervous system. And when these patients have these infections, these oligoclonal bands are targeted against the infectious organism causing. So what could they possibly be in MS? Well, I'll tell you, we've been looking now for 20 years for what that target is, because this is telling us that it might be important and targeted against what the nervous system is looking at. And I'll finish up telling you that I think we have the first one that we now can start testing for. So what about treatment in these two disorders? We know in neuromyelitis optica, the attacks are rather severe. And therefore, after 5 years, about a fifth of the patients are going to need a cane to walk. And after 5 years, about 40% are going to be blind. So yes, we treat that. In MS, we know there's smoldering disease. that a mean time untreated to disability requiring a cane could be about 15 years, and it can be shorter if patients start with problems in the spinal cord. So yes, we treat multiple sclerosis right away. So how do we treat them? When it comes to acute episodes of dysfunction, we generally treat them the same way, steroids, okay? And if it's not steroids and it's severe, we wash out your blood, and that's called plasma exchange. And if it's preventative treatments, we try to suppress the immune system in NMO, and we try to modulate it in MS. And sometimes we have a special therapy, knowing that complement's involved in NMO, and we do anti-complement therapy there. And that may come as we talk around the clock for MS eventually. But let's take a look a little bit more closely. You all know that you get high-dose steroids when you have attacks in MS. In fact, just like you might have very brisk reflexes, neurologists have very brisk reflexes too for steroids. So if you have an attack of demyelination, what do? We give you steroids, okay? And just like a brisk reflex that doesn't stop, sometimes we don't stop. We keep giving it over and over and over again to try to make it calm down. And sometimes that doesn't work and we do plasma exchange, but steroids in MS are interesting because they tend to speed up recovery, but they've never been proven to actually benefit recovery. And unfortunately, in neuromyelitis optica, what I'm showing you here is that it's pretty rare, despite steroid treatment, to return to baseline. 14%, so we got 12% if it's a very severe attack and we make sure that you return exactly to where you were. If we give you a break and say you're getting close to where you were, maybe it's about 15%. But no matter how fast we give steroids, we don't get you back to the same place. So steroids get you back faster, but no one's proven that they're getting you back to roughly the same baseline. But we know from treating optic neuritis that perhaps maybe the faster we give you steroids, the better we can do it. So we're thinking that we need to do clinical trials in both disorders to show if we're really rapid about giving steroids, that perhaps we could make a difference both in visual function, as shown here for optic neuritis, people getting steroids within 3 days or less, or in terms of that OCT where we blink light against the back of your eye and measure the thickness of the optic nerves, that in those cases, we actually have more preserved nerve after treating earlier. When it comes to the preventative treatments, I'm going to show you that there's a long list of therapies, thank goodness, that we have for multiple sclerosis. And I'll tell you that only some of these therapies have been tried and are, they don't do much for neuromyelitis optica. But paradoxically and importantly, this is a list of therapies that make neuromyelitis optica worse. So you have to know which way you're going and what disease that you have. So of course, when this was first discovered, we tried a lot of therapies we had for MS, and we had to learn the hard way that this was a separate disease. And there are some common ground treatments, especially the B-cell depleting treatments that work excellently in both disorders. What is our treatment strategies? Generally for both disease, it's start and don't stop, okay? But in neuromyelitis optica, we have a little benefit that we don't have in MS. And that is in neuromyelitis optica, there isn't any progressive phase to disease. Everything is attack driven. So if we prevent attacks, we're preventing the disease from making people progressively worse. And so attacks are the cause of disability in neuromyelitis optica. And so the strategy obviously is attack prevention. And for this disease, we have several immunosuppressive therapeutics that were tried when we first learned that this was a separate disease. But now we have 3 approved therapies finally that just got approved about as early as 5 years ago. And off-label, we can use rituximab as seen below. And that's very similar to inabilizumab, but not quite the same. This is an anti-CD19 depleting antibody, and This is an anti-CD20 depleting antibody. And the differences are significant, but not worth the conversation at this level of discussion. So what do we have? We have that now we knew we had a specific disease, we were able to reduce relapse frequency. And to put it into words, this means one relapse every 10 to 20 years, effectively, with these therapies, knowing what the cause is. So we learned about a target, we learned about biology, and we developed specific therapies. And now we can target to try to tolerize people against that target, which means basically we can essentially vaccinate to reduce inflammation. And what our group recently published for MS is very exciting. And this is schematically shown here. What we've done is go to the spinal fluid of multiple sclerosis patients. And we collected those cells independently, single cell by single cell in a dish. And we looked at what single antibody that cell was making. Why? Because I told you the oligoclonal bands were made in the spinal fluid of patients. So we wanted to say, we don't have to ask you for your spinal fluid over and over again. Just give it to us once and we'll make all the antibodies it's making on our own forever. And so we made those antibodies and we looked at what they were reactive to. And we found a target. And this target is a part of myelin called proteolipid protein 1. And it was in a very complex formation in the membrane, and we had to reproduce it by adding a bunch of extra components. And Greg Owens in the lab, longtime investigator, was able to establish these conditions. And what did we find? We found that these antibodies, when injected into animals, like the NMO antibodies, would cause pathology. Did the pathology look like NMO? No, it looked like multiple sclerosis instead. And what about it? Here's MS patients who have the antibodies in their spinal fluid. Here's controls. So we have an antibody target now that represents the first specific test for MS, and it identifies roughly now 60% of all MS patients. Who are the other 40%? We know there's a partner in here, and just a few days ago, I think we've come across what that partner is, and I think we'll have many of these other patients and get closer to what would be all patients identified with multiple sclerosis. And so what can we do now? We can look at who has what antibody, what sort of disease course they have, how do they respond to therapy, and can we introduce tolerance to this and stop the disease? So we have a tale of two disorders with different targets, at least aquaporin 4 on astrocytes and NMO, and now I'll tell you PLP1 complexes on oligodendrocytes in multiple sclerosis. They have distinct activities, MS continuous and intrinsic inflammation in the nervous system, NMO relapsing activity, peripheral antibody that's made and gets to the nervous system, and two distinct treatments, but commonalities for acute treatments, but different chronic treatments. And this is how this field is going to move forward. So thank you very much for your attention.